Remember the case of Richie William, the child who died from a simple yet bungled procedure at the world's most famous children's hospital.
He was on the path to recovery. He was in remission, and so things were looking up.
When Dr. John Lee injected 12-year-old Richie William with the poisonous vincristine, he was seen by most as being incompetent and culpable of manslaughter. Even expert witness Professor Alan Aitkenhead, asked to look at the case for the prosecution, had the same thought.
On the basis of that first set of evidence which I saw, I felt that this series of errors and failures to check on the part of the anaesthetist did indicate that he had fallen seriously and significantly below the standard of care expected of him.
But then, 6 weeks before the trial began, a package arrived.
Instead of a half-inch bundle of documents, which I'd seen initially, I was sent a large cardboard box containing a lot of additional statements, a lot of additional evidence.
For unknown reasons, the police had withheld this information. What emerged was a much more complex picture of small mistakes all the way down the line, leading slowly but directly to Richie's tragic death. When Richie arrived at Great Ormond Street in the early hours of July the 25th, 1997, doctors discovered that he had recently eaten a biscuit. This one digestive biscuit turned out to be the bizarre catalyst that defied the hospital's safety procedures and led to Richie's tragic death. Richie was terrified of needles, and spinal injections are painful, so Richie was always put to sleep before his treatment. But because Richie had eaten the biscuit, his treatment had to be delayed.
It's very important before any general anaesthetic that patients are starved, because of the risk that if there's anything in the stomach it can be vomited up while the patient is unconscious, and that can be very dangerous. So the fact that he'd eaten the biscuit meant that the general anaesthetic had to be delayed, and therefore he couldn't be done on the operating list during the normal time that it was due to run for, while a haematologist was there to perform the procedure.
Richie and his mother were taken up to a general children's ward and left to wait. Dr. Dermot Murphy, Richie's consultant, who was due to administer the lumbar puncture in surgery, finished his shift by lunchtime. He assumed Richie would become the responsibility of the afternoon staff. Richie's 2 chemotherapy drugs were ordered up from pharmacy: methotrexate, which was to be injected directly into his spine, and vincristine, which was meant to be injected into his arm. Normally, intravenous chemotherapy like vincristine would be administered by a trained nurse in a specialist ward. The operating theatre should only be dealing with the methotrexate injection into the spine. Both drugs were sent together to the ward where Richie was waiting. But as he wasn't in a cancer ward, the nurses didn't know the drugs were to be kept separate. So they sent both to the operating theatre with Richie.
That was a mistake which should not have happened. The hospital knew that disasters of this type had happened before. They had told 2 of the wards, and they had told 2 staff in 2 of the wards, that both drugs should not go to the operating theatre, but they were admitting children with this condition and requiring this treatment to other wards where the nurses were not aware of the dangers of sending both drugs to the operating theatre.
On this occasion, the anaesthetist, Dr. Lee, persuaded Richie to have a local anaesthetic, citing a much shorter recovery time. Richie was initially unhappy, but in the end agreed. John Lee contacted Dr. Dermot Murphy to ask who would administer the treatment. Murphy explained to Lee that it was a simple procedure, and as the boy had agreed to a local anaesthetic, only one doctor need attend. So he told John Lee to administer the drug himself. At this point, Dermot Murphy had no idea the vincristine was in the operating theatre. It wasn't allowed in surgery as part of the hospital's safety measures. So when Murphy told John Lee to give the chemotherapy drugs pharmacy had sent down, he was assuming there was only one drug in the theatre. Dr. Lee, even though he wasn't experienced in administering chemotherapy drugs, wanted to make sure Ritchie got his treatment that day, so continued with the procedure. He had no idea he was killing the boy. Professor Alan Aitkenhead assessed all the new evidence and gave the courts his considered opinion.
He did make a mistake, but in my view it was much less serious and significant. In other words, it was a mistake which, whereas previously I had thought no reasonable doctor could have made, or a series of mistakes which no reasonable doctor could have made, it was now, in my opinion, a mistake which many doctors could have made. Still a mistake, but not nearly as serious as had appeared initially.
Based on this evidence, the court found John Lee and Dermot Murphy not guilty of manslaughter and dropped all charges against them.
The last 18 months have been very difficult for me and those close to me. I am very pleased that it has been accepted by the prosecution and the court that there is no case against me.
Ritchie's tragic death was typical of many medical errors. At first, it often seems that there's an easy villain to blame, an incompetent doctor or nurse. But as the facts emerge, we find a much more complex picture. In this case, the blame has to lie with the hospital itself.
The real error, or the real errors, were made, in my view, by the hospital in allowing a system to exist in which both these drugs could end up in the operating theatre with the patient, with an individual who was not trained to administer them, and in the expectation that he would administer them.
So when we look for ways of reducing medical error, perhaps we should abandon the hunt for the guilty individual and instead focus on the system itself. Next week, we explore why medical systems, not doctors, are killing us.